My case is Impella Assisted calcified, unprotected left main trifurcation PCI in a patient with a renal graft. My patient is 72-year-old male with recent anti-VLMI, moderate LV dysfunction, who is hypertensive, diabetic, and had a renal transplant 7 years before, and with a good allograft function and EGFR around EIT. So this is his LV. You can see there is definitely more than moderate LV dysfunction with preserved thickness of LV, and viability was seen. It's a viable territory. And this is an angiogram. You can see a tight lesion in LCX, and it's a left dominant system. And you can see a trunk tract calcium in LM extending into LAD as well as LCX. And there is a big ramus. And this is a non-dominant RCA, which is filling LAD. Yeah, so it's a high syntax score. So with and patient also had high Euro score and STS score. We had a look at iliofemorals with a plain CT and Doppler. That's what we are doing wherever we don't want to give contrast. So the caliber is okay and there is no circumferential calcium in CT. So we had discussion between high-risk CABG versus protected PCI, but patient was not willing to undergo bypass. So then we ended up only with protected PCI. So why protected PCI? This patient, diabetic, elderly, heart failure, ACS presentation, and also post-renal transplant. Hemodynamically, there is already moderate LV dysfunction, and his admission in earlier hospital, in fact, he also received inotropes for almost 12 to 24 hours, but by the time he reached our hospital, he was stable without inotropes. And anatomical complexity, it's a too complex anatomy to handle, like left dominant with the trifurcation and calcified lesions. And of course, you need mostly, atherectomy devices, as well as you may end up in using guide extensions too. And we did a right heart catheterization, which aptly was mentioned by Dr. Swami yesterday, which makes sense many times. You can see his PA pressure was quite huge, and LV-EDP is also quite significant. And that's when we took a decision to go ahead with Impella. We placed Impella, and this is the first injection. We wanted to treat LCX first. We wanted to do rota into LCX first. Because anyway, LAD is totally occluded and filling from right coronary artery. So the chances of creating no flow into all vessels will be low. That is the idea. That's the reason I started. We did IVs from ramus as well as LCX first. We can see it's the LM, this is ramus. You can see the calcium in left main. So it's almost like 360 degrees calcium. And this is IVs from LCX, which clearly showed again, ostial LCX is calcified, and also distal LM is significantly calcified. So with this is a distal LM. And this was, we were recording live in box, so you can see the movements, what happened. So when I started rotablation into LCX, you can keep watching here. You can keep watching this pressure wave in aorta. So the moment I sent bar inside, the next patient went into VA uncoupling. You can keep watching here. Yeah. So this was a pressure, and now you can see there is no pressure. So that's what happens. So, and that's when Impella really saves. You can see, in fact, we pushed Impella into a boost mode, though our mean pressure is maintaining. And you can see a prolonged AV uncoupling, so with rota. So then we started pre-dilating LCX. You can again see when I pre-dilated LCX, so what happened, keep watching here. So we just pre-dilated again, the pressure started dropping, and at some point it goes into complete uncoupling. So this is what happens when you have a dominant LCX and LAD is totally occluded. It's almost like a single surviving vessel. Every time patient will go into hypotension, and if there is no hemodynamic support, probably it's very tough to do such cases. So you can see this is how calcium is ablated, and then we crossed into LAD with a microcatheter support, and then I did a rota since anyway I already opened it, and then we did a IVL, so into LAD, as there is circumferential calcium despite rotablation, and then we started stenting, mid-LAD fast, and then took a bifurcation stenting. You can see here, see, mere placement of stent in ostial LCX and deployment of stent in, even just placement also caused patient to go into uncoupling. And when I deployed, and again patient, you can keep watching pressure, he goes into uncoupling again. So these kind of repeated uncouplings happened with, because there was an Impella. Otherwise, I think I wouldn't have, we wouldn't have even completed procedure. So then we went ahead, did a DKS to LM bifurcation, see this LCX stent. Then we crashed, recrossed, and then did kissing, first kissing, and then this is LM to LAD stent, and did a pot, and subsequently recrossed again, and optimized, and then did a final kissing followed by final pot. And this is what I made out. And it's entirely done with IVUS, so we were not sure, what is happening into the ramus till this injection. So this patient with a moderate LV dysfunction, with such a big ramus and already a partial infarct in LAD, I thought, I have to open this ramus. So then we decided to open this ramus. That's when, I took another puncture. So there is no need to take another puncture. You can go through Impella sheath. So this is what you can do. You can puncture at 2 o'clock or 11 o'clock in Impella sheath and put a 6 French long sheath through the Impella sheath, and then take a 6 French guide for third, third wire. So we took third wire into ramus through the second guide, and we opened, but despite that, there was 70% lesion in IVUS, so we decided to even stunt it, followed by double kissing and trissing, and this is a final result which we have got. So this is a final result which we have got. And these are the final areas, so good areas. And we achieved final residual syntax score less than 4, mainly because we had a hemodynamic support. But before weaning off Impella, again we rechecked PA pressure and LVEDP. You can see there is a significant rise in LVEDP. Then we did a lactate, and this lactate actually increased, which was 3 before, went to 7. So this was a bit shocking to entire team, and we decided to continue Impella, no point in weaning off. This is what exactly happens. So recurrent ischemia with a balloon, we think it is a transient effect. Not at all. It can have a consequence because it definitely have a prolonged effect. So we continued Impella for next 12 hours, and slowly his PA pressure dropped, and also his PCWP dropped, and also lactate came down to 1.2, and then we removed his Impella, that is 12 hours post-procedure. Yeah, to conclude, right heart catheterization is essential in CHIP PCI to assess post-procedural wean-off of Impella. That's very important. And LMCA bifurcation, trifurcation PCI in calcified lesions every step can cause decompensation and hemodynamic compromise. And rotablation, IVL in LMCA with a dominant LCX is a perfect substrate for hemodynamic instability. Impella gives operator uninterrupted time for complete revascularization. And last but not least, balloon occlusions has prolonged stunning effect. We shouldn't think it's only transient. Thank you.
I think superb case, sir. Extremely well demonstrated, and right from the planning to the execution to the follow-up, everything was, exemplary. It really illustrates the importance of having an LV assist not only during the procedure but after also, because you might get away during the procedure, but often patients, because of the stress of the procedure and the stunning caused by the repeated ischemia, actually are not going to come back so easily, and it requires even more intensive and careful monitoring to actually get them off. I think leaving the Impella in until making the hemodynamic judgment that it is time to remove it is absolutely key. Again, anything different that we could have done? This is just
For
taking advantage of your experience.
Yeah, see, the only thing I would have done is into the dominant LCX, probably I should have used only IVL instead of using Rota. But see, since Impella is there, so that, I don't think too much, when there is an hemodynamic support. Had there was no hemodynamic support, I wouldn't have ventured to do a prolonged dilatations or even to do an rotablation into unopened LCX. That is like
any
final
argument
nail.
for doing LAD before LAD first?
Yes, if I had not used mechanical circulatory support, I would have done LAD first. Why I did LCX is, my thought process, I'm telling you, I may be right or wrong. When I'm doing rotablation, I don't want no flow into these vessels. Since LAD is already totally occluded, so if I open and then do rotablation into both, there is a chance I may create no flow into two vessels. Since it is already occluded, at least my LAD is saved. I'm not going to create any no flow into LAD. That's a thought process which I had, before doing this.
And
that's the reason I did LCX, then I opened LAD.
Just off the cuff, when would you consider an additional ECMO?
So it's all about, PAPI. So what your RV function parameters are. So that's the reason that also emphasizes, right heart catheterization, before putting an Impella. If patient already had an RV dysfunction, so that can be assessed both with the non-invasive as well as invasive. We always take, before we think of Impella, we always take RV function parameters of non-invasive, that is the tissue Doppler and all the stuff. And next, during, before procedure, PA catheter, where we take PAPI. You must have seen PAPI of this patient is more than 3.5. That clearly says it's a good RV. So in that case, you can use simple left-sided percutaneous assist device. If PAPI is also low, you may end up in, putting a VA ECMO. I think in first place, you have to think of VA ECMO.
I think it's a great
My question
point.
is for the, anyway using an Impella, you have an LV EDP of 20 to begin with. If you had probably put in the Impella 24 hours earlier, would the LV EDP been better and your outcome of the final LV EDP been better? Thought process.
It's a good thought. We can do it, but again, the practical concerns of, implanting Impella 24 hours before and moving such patient, ICU back and back to cath lab. So instead, few operators are doing like put an Impella, leave for 1 to 2 hours but you have to dedicate the lab. So that's a problem again in most of the Indian labs, the next patient is waiting. So putting for 2 hours and then, doing procedure, that's something, we can do.
Sharath, that's an awesome case. Very meticulously planned and executed. Just a couple of points. Would you also suggest at the end of this case that every time you want to wean, wean off Impella following a protected PCI, you would always want to look at the PA pressures and parameters before you decide on weaning off whether it has to be immediately removed, the Impella has to be removed immediately, wait for 6 hours, 12 hours. Should that decision be based on the numbers that you get from the PA catheters, number one. Number two, you're working with a little less of contrast, right? So that Ramus was a huge vessel. So was there any role during DK crush? Let's say there is a small possibility that we could have occluded that particular huge vessel. You had TIMI 2 flow, you are fortunate enough to have wired it again. Was there a role for protecting that with a wire and a balloon while deploying the LED stent or so?
For Ramus?
Ramus.
Yes, I mean, that I should have done. Yeah, I should have done. And coming to the first question about, measuring hemodynamics before deciding on Impella. So that's very, very important, because whether simple left-sided assist device is enough or not, that is the first question which you have to answer. And the second question is, while weaning off, so you need to be at least there where you started. That is, all your hemodynamic parameters should be similar to what it was at the start of the case. Then only you have to wean off. If any deviation, so high PCWP or high lactate or high PA pressure or high PA mean pressure, so all these things are not a safe parameters to wean off your hemodynamic support. So any difference from where you started makes sense to continue Impella. And another reason is a patient who had so many VA uncouplings during the procedure. See, every uncoupling is an evidence of stunning during the procedure. So, and the data which I showed, every stunning can have a prolonged effect. So, in such a situations of too many VA uncouplings and changed parameters, it always makes sense, you continue. And that is the reason we have to do a PA catheterization before and after, so which makes you more sensible in taking decisions of wean off. That's it.
Nice case, Sharath. Just one question. You had a transplant. Your Impella was on which side?
Oh.
On the opposite side.
On the opposite side, yeah.
And then you had a sheath on the other side, I suppose.
Yes.
Your procedure was from the other side.
Procedure is from radial.
Okay.
Radial. We have not used the transplanted side artery at all. Yeah.
That's one question.
And that is the reason I had to take ship.
Yeah.
When I had to use a second guide, I went through the Impella sheath.
Second question is, obviously the issues of Impella vascular complications and bleeding. You may have a great place to look at all that, but would you at that point of time downgrade to intra-aortic balloon pump and come off so that the vascular complications are lesser from the Impella?
But with this kind of parameters, I would love to continue Impella.
Okay.
So.